these complications. And for discussing about this important topic on community-acquired pneumonia and its complications, we have with us Dr. Amita Kaul. She is head of the Department of Pediatrics at Surya Mother and Child Super Specialty Hospital, Pune. Welcome, ma'am. You can please start.
Thank you. So I will be talking about complicated community-acquired pneumonias in children. So what is the definition of community-acquired pneumonia? So basically, what is pneumonia? So we know WHO has made it very simple for even Anganwadi workers to recognize pneumonia. So cough or difficulty in breathing plus age-specific fast breathing becomes pneumonia. So if a child comes with fever and cough, there's no pneumonia. If the child comes with fever, cough and fast breathing, it is pneumonia. And if child comes with fever, fast breathing and other signs like retractions or poor oral intake or dull, drowsy, it becomes severe pneumonia. So it's a very simple clinical diagnosis. So presence of signs and symptoms of pneumonia in a previously healthy child due to an infection that has been acquired from the community outside the hospital. So that is how we define a community acquired pneumonia. Then why are we so bothered about pneumonia? Why only are we talking about pneumonia? Because the pneumonia deaths are huge. In world, under 5 pneumonia deaths per year around more than 7 lakh. And India itself is more than 1.27 lakh per year. And we are the second highest national burden of pneumonia deaths in the world, first being Nigeria. So that's why we need to understand the disease, see why is it and how we can control the disease and prevent mortality. Then why do children die of pneumonia? There are certain risk factors which subject these children to death. The number one is malnutrition, which is wasting. 53% of children who die are have malnourishment. The other causes which may cause death are exposure to pollution, air or indoor pollution. And there's a lot of inequality in when we see the statistics. So in communities which are richer, under 5 mortality is less. It's like 3 times lesser. Like under 5 mortality, this is we're talking about the complete under 500, not just pneumonia. 72 per thousand live births in the poorest household in our country versus 23 per thousand in the richest communities. And state wise also, UP has a high mortality of 78 per thousand, which is only 12 times more than Kerala, which is just 7 per thousand. So then coming what is the clinical presentation of pneumonia? So systemic signs like fever in smaller children, like infants, poor feeding, lethargy, malaise, even in older children can come with headache and myalgias. Then the pure respiratory symptoms which children come are cough, fast breathing, nasal flaring, grunting. Then if the pneumonia is severe, there's subcostal retractions, intercostal retractions. On auscultation, there are crackles. And if there's fluid, there may be decreased air entry. And if you percuss, there'll be dullness. So in children, smaller infants, they may not have purely respiratory symptoms. They may come with fever, with poor feeding, sometimes even apnea. And older children may come with more of localized symptoms like chest pain, and sometimes they may even have referred abdominal pain. We see a lot of children who come with high fever and abdominal pain, and people are writing anti-oflox, metronidazole, and it finally turns out to be pneumonia with complication with a effusion with pleuritic chest pain, which is referred in the abdomen. So if a child, you should always examine the child even with abdominal symptoms with high grade fever for proper chest signs. So tachypnea threshold by age as given by WHO are if less than 2 months, more than 60 per minute, 2 to 12 months, more than 50 per minute, 1 to 5 months, more than 40 per minute, and more than 5 years, more than 20 per minute. So these are the tachypnea threshold by WHO. Then what do you do clinically? So basically pneumonia, as I told you, is a clinical diagnosis, but in certain circumstances we have to do tests. So if a child comes to your ER or the OPD with clinical diagnosis of pneumonia, it is very important to do a pulse oximetry, because pulse oximetry will help you tell about the oxygenation of the child. If the child is hypoxic, definite will need hospitalization. What about blood tests? So as in a routine OPD practice, you do not need to do tests, but yes, if a child is sicker, you're admitting the child, you can do CBC, CRP. Blood cultures are also important in hospitalized children. So OPD basis, we generally don't do blood cultures when we are suspecting pneumonia. We just clinically diagnose pneumonia and probably start antibiotics. But if you're hospitalizing a child, we do blood cultures. So blood culture yield in pneumonia may be less. It may be like in 20-25% of cases of pneumonia, you may grow something. And which pneumonias? Mostly bacterial pneumonias, especially strep pneumonias, you can have culture positives. Staph pneumonias, you can have culture positives. And but prior use of antibiotics, the child has already received oral antibiotics, and when you send culture, so that there is 50% chance that you may not grow anything. But it's always a good practice if you are admitting a child to send blood cultures. It helps you guide your antibiotics better. Then imaging again in OPD basis on a mild pneumonia, so you need not do X-rays, but X-rays should be done in child where the child is hospitalized, is hypoxemic, has more distress towards severe pneumonias. And ultrasound focus has become very routine practice these days. In our ICU, we routinely, if the child is admitted with pneumonia, we are doing routine ultrasounds to see, because effusions come earlier in ultrasound rather than X-ray. So if the child is admitted for some reason for pneumonia in ICU, daily ultrasounds are done to see the progress of the effusion increasing, decreasing. You can see the shed sign in focus. But for OPD basis, or where you're suspecting an effusion, or a child is in ward, we generally don't do ultrasounds that frequently. So obviously you will be doing ultrasounds for to confirm and characterize the effusion. Then what about microbiology? So if the most common things which we are doing these days are PCRs. So we do nasal PCRs these days. Nasal PCRs are very good when you're diagnosing viral infections like right now there's an epidemic going on in Pune. I don't know about Delhi. Influenza A, H1N1, RSVs. So they are very easy to diagnose if if you are able to isolate a virus through a PCR. But if in a sterile fluids, like in a pleural fluid, if you're able to do a PCR, it gives you more information. So for if you're sending, if there's an effusion, you're sending pleural fluids, we generally send for gram stain, culture, cell count, biochemistry, and if whenever possible, if the patient is affording, we do a PCR as well. Cultures obviously would have a lower yield, but should always be done because we have already given antibiotics. We generally don't do tapping before start of antibiotics. We always the child has received it in the OPD, then later in the wards, and then tapping is done. And PCRs also help us diagnose atypical infections like mycoplasma. Mycoplasma is hard to diagnose because mycoplasma is not easy to culture. We never see mycoplasma culture positive. So it's the PCRs which help you diagnose and will help you rationalize your antibiotics if it's mycoplasma or you get a viral panel positive. So what are the common bacteria which cause or common bugs which cause pneumonia? So in less than 3 weeks, it's mostly gram-negative bacteria, E. coli, Listeria. Group B Streptococcus, it's not very common in India. 3 weeks to 3 months, we see RSV. Last year we had a lot of RSVs. Right now we have not isolated much, but last year it was abundant RSVs. You have Bordetella, you have Chlamydia. 4 months onwards, you have viruses. Currently, as I told you, influenza is very high on cards. Adenovirus, human metapneumovirus, RSV, parainfluenzas. Strep pneumonia is one of the commonest bacteria in all age groups, which causes pneumonia. So it's obviously you have to think of strep pneumonia when you're writing your antibiotics. Staph is another bacteria, group A Streptococcus. And more than 5 years again, strep pneumonia is the commonest. Mycobacterium becomes a very common bacteria which causes pneumonias in the school age groups. Then this is one study which we did. We All the children who are admitted with pleural effusion, and we send the pleural fluid. We send it for PCRs along with culture. So we what the commonest bacteria we isolated was strep pneumonia in 64.6% of patients. Second was mycoplasma, very it was surprising for us as well, and staph, which came at 6.3%. And there were a lot of other co-detected viruses, RSV, influenza, H3N2, adeno, parainfluenza, and rhinovirus. Then when do you admit a patient of community acquired pneumonia? So hospitalization, obviously, if a child is desaturating, there are moderate to severe signs of respiratory distress. A infant, a 3 to 6 month old infant, it is always better to admit such smaller children for IV antibiotics, and where the clinical suspicion is towards a more virulent organism like an MRSA. Child is sick looking, child has, you've already given oral antibiotics and child is not improving, or there's a child with underlying comorbidities like a child with a congenital heart disease, an NICU graduate with a chronic lung disease, or some sort of a neuromuscular disorder where the infection may become more virulent or the antibiotics may not reach and the child is immunocompromised. So it is always better to admit and administer IV antibiotics. So when do we escalate to intensive care? It's very, very obvious. Obviously, when the child is needing respiratory support, which could be a non-invasive respiratory support or HFNC, you're needing mechanical ventilation, child is very sick, has severe distress, needing ventilation, or child presents to in shock, where the BPs are low, decompensated shock, or your saturation, you're needing high FiO2s, child is drowsy due to hypoxemia, whatever the reason. So these are the criterias where you directly admit the child into a intensive care unit. Then what can go wrong in a community acquired pneumonia? So whenever a child comes to you with community acquired pneumonia, we have to always think what can go wrong and keep assessing a child for these complications which are very, very common. So parapneumonic effusions or empyema, where there's an exudative phase, then you have a fibrinopurulent phase, and then finally organized phase. You have a lot of children develop necrotizing pneumonia where there's cavitation, there's liquefaction of lung tissue. Lung abscess is another complication of community acquired pneumonia. Bronchopleural fistula is a complication where there's a necrotizing pneumonia and child develops a bronchopleural fistula and you need to put ICDs, or there's persistent air leaks. Sometimes the bacteria is very, very virulent and the child can present sepsis and septic shock. And there could be a metastatic infection where the infection is not just limited to the lung, it goes to other parts of the body. There could be osteomyelitis, septic arthritis, there could be endocarditis. So these things you can only diagnose when you suspect that the child is not getting better. So you have to find the cause for child not improving when you have already diagnosed a child to have a pneumonia. So let's do some cases. Let's go through some cases. So there's this 3-year-old child who's comes with a history of fever since 4 days, cough, cold for 2 days, and febrile convulsions for 4 days back, which lasted for 30 seconds, terminated spontaneously. On admission, he is tachypnic, his RR is 60, he's hypoxic, his saturation is 75% at room air, and air entry is reduced on the right side. Obviously, he's admitted to the ICU. He's taken on HFNC support and he's needing very high oxygen, 50%, and just saturating borderline 90 to 92%. So we sent in the labs and we get a hemoglobin of 10.4, TLC of 930, okay, an ANC of 660 with a platelet count of 34,000 and a very high inflammatory marker CRP is 260. And this is the X-ray of the child. So what organisms are we suspecting here? Can we have some interaction? So what is it? It's a viral pneumonia, it's a bacterial pneumonia. What is the X-ray picture showing? Can somebody answer on the chat or audio? So nobody's answering. So, which antibiotics would you choose here? So, as I told you, whenever you are diagnosing a pneumonia, you should always think which is the bug which is causing this. So, antibiotics are going to be according to the bug you're suspecting. So, the choice is ceftriaxone, linezolid, ceftriaxone, vancomycin, or the child is very sick, you want to give piperacillin, tazobactam, or vancomycin plus vancomycin. So in this child, we chose ceftriaxone, we chose linezolid, and we chose oseltamivir because the child had low count, so it could be an influenza followed by a secondary infection. There's a lot of effusion, the inflammatory markers are very high, and there's both lines, platelets are also less as well as TLCs are also less. So there, because there is effusion, you have to, whenever there's a focus of infection, you have to remove the focus. So under platelet cover, we did a tapping, and this is the kind of fluid which we got. It was like an anchovy sauce, like very different kind of fluid. We were not expecting this. and we sent it for cultures as well as PCR, and the PCR isolated strep pneumonia. So PCR fluid is strep pneumonia. So obviously we continued the child on ceftriaxone. Linezolid we don't need because linezolid was added because we thought it could be a staph infection because of the kind of the way the child was sick with low counts and very high CRP. But once you get your PCRs there, you I have isolated the bacteria. You can obviously modify your antibiotics and de-escalate them. So ceftriaxone was continued. Child responded well once we tapped the child. We shifted the child out of PICU on day 4. He had no distress. He started to eat. He was better. But he was having continuous low grade fever, and one evening on rounds, the resident picked up that he is desaturating. So obviously an X-ray was done, and this is what we saw on the X-ray. So what is this on the X-ray? We see a hydropneumothorax. So why should this child develop a hydropneumothorax? Because strep pneumonia is a very invasive bacteria and probably cause necrotizing pneumonia. And so the child was back in the ICU. We had to put a pigtail, drain the fluid as well as the air, and eventually this child had necrotizing pneumonia. And despite putting an ICD, the child had a continuous line of fluid which was not getting drained by ICD, and the child needed VATS. So and after that, after 4 weeks of antibiotics, we were able to send the child home. So what is the important thing about the strep pneumonia? Strep pneumonia this is a leading bacterial cause of pediatric pneumonias and empyema. Lobar consolidation with high grade fever is the clinical clue, and it progresses very rapidly to parapneumonic empyemas, and the treatment is very simple. Most of them are sensitive to ceftriaxone. Lot of areas are getting ceftriaxone resistance, so vancomycin can be used. And the key point here is that in a child you have already isolated a bacteria, the child is not getting better, there's no point in changing antibiotics. The problem here is source control. We did not control the source initially because of the low platelet. We thought we tapped and we drained as much fluid as we could. But the bacteria was there, the fluid, there was empyema, and then which led to necrotizing pneumonia. So the child needed surgical this thing to control the infection rather than switching of the antibiotics. Then a second case, we have a 7-year-old child who had fever for 10 days, cough since 5 days, and loose motions. When she was admitted, she was saturating well. She was admitted in the wards. So we gave ceftriaxone, oseltamivir, and azithromycin. So the age group is 7. So we thought of probably if the child could have mycoplasma. So we added azithromycin as well. We did a nasal PCR and it came to be negative. And then in the wards, the child started to deteriorate. The fever became high, 104. She developed distress. She started desaturating and obviously needed ICU because she needed oxygen. She was put on high HFNC. And so now what were we thinking in mind? Now the child is deteriorating. We have given strep cover. We have given Mycoplasma cover. Now what is left? Because child is deteriorating, we thought probably it could be a staph infection. So we started linezolid for the child. The chest X-ray and ultrasound done. Then suddenly there was a fluid accumulation which was not there in the initial X-ray, and in 2 days the fluid collection increased. So this is the X-ray on admission and the X-ray done on the third day. You can see the fluid accumulating in the right side of the chest. So obviously the source is there, so we tap it. So pleural tapping was done and pleural fluid PCR detected mycoplasma. So obviously we were already covering for mycoplasma. So probably the child did not respond. Number one reason could be because the fluid was there. So after remove the fluid, you control the source and azithromycin started acting. The other thing which you have to think whenever you are dealing with a child of mycoplasma not getting better, could it be a macrolide resistant bacteria? Because it is very common, as mycoplasma cannot be cultured, you cannot have an antibiotic and you don't have an antibiogram to tell you whether it's resistant or not. So it's clinically, if a child is not getting better on your azithromycin third day, fourth day, or getting worse, so you have to think in lines of a macrolide resistance. So here we gave doxycycline, and after fluid removal, child became afebrile, and we were able to discharge the child on day 7, day 8 of admission. So how do you diagnose mycoplasma? As I told you, it's not you can't culture mycoplasma routinely. So you have two ways. Either you do a nasal PCR or you send a IgM serology. Nasal PCR detects Mycoplasma DNA directly, so it can be positive from very early part of the illness. It's preferred for acute diagnosis. But the problem with nasal PCR is you cannot distinguish between an infection and a carriage. And it may stay positive for a longer time even when you have treated the infection. IgM serology, it detects the antibody response but not the organism. It comes positive in the second week of illness, and it may be blunted in smaller children. And there's a lot of false positivity in when we are doing IgM serology. So generally in our unit we prefer a PCR to IgM serology. So what is the teaching point of Mycoplasma? Mycoplasma generally they are called as walking pneumonias, and they don't have cell walls. So all your antibiotics which act on the cell wall like ceftriaxone will not be acting. So the clinical clues are that it's a school-age child, prolonged cough, fever, headache, non-specific symptoms. Sometimes they come with extra pulmonary symptoms, which could be a rash, hemolytic anemia, encephalitis, arthritis, which is basically because of immune response to the bacteria. And here you have to treat other than antibiotics. Sometimes you need to give steroids, sometimes you need to give IVIG in these patients who come with immune manifestation of the bacteria. Diagnosis, as we've already discussed, PCR is the diagnosis because you can't culture it. And macrolides are the drug of choice. And macrolides are azithromycin, erythromycin, clarithromycin are the same group. So if the one child is not responding to azithromycin, there's no fun in changing to clarithromycin or erythromycin. So you go to doxycycline or you go to fluoroquinolones like levoflox in these children. Then coming to the third case, we had a 11-year-old child who came with history of fever, very high fever for 6 days. He was coughing. He recently had a fracture of his right humerus and was wearing a cast. His counts were relatively normal. Hemoglobin was 12.7, count 6,800, platelet normal, but CRP was extremely high. He was started on ceftriaxone, fluids, and other supportive care, and this was his x-ray, so you can see a small patch on the left side. And then on day 2 of admission he started to limp. His main complaint, he obviously was having high grade fever, but he was having pain all over the body, and we localized the pain to shoulder where he had the fracture and hip. So ortho review was done on this child, and then we planned an MRI for both shoulder and the leg wherever the pain was, and we found out that in the shoulder he has a periosteal abscess and there are signs of osteomyelitis in both the leg as well as the shoulder. So obviously we whenever there's pus you have to take out the pus, and otherwise the child will not going to get better. And whenever you find such metastatic lesions, the first bacteria which should come to your mind is a staph, and that to MRSA. So once we got the reports, we added vancomycin to this child, and good part was the child, we were able to isolate MRSA on the blood culture itself as well as joint pus culture. And so it was a MRSA, so we just stuck to vancomycin. And once we did debridement and decortication, child started to improve drastically. The fever reduced, and gradually the inflammatory markers also reduce. So staph is something which causes metastatic seeding, so you have to be very, very careful. So rapid deterioration is a clinical course, especially after influenza-like illness. Or you should always see for a history of any skin infections. We have a lot of times we see children. We had recently had a child who had a cellulitis. Came for cellulitis, septic shock, and cellulitis improved, and suddenly the child developed distress. And we did an X-ray. We found empyema there. So staph is known to cause these things. So you will have to keep screening the children where you are suspecting staph for metastatic lesions, a new joint effusion, or a focal bone tenderness. And the other thing is blood cultures. If your blood culture for staph is positive, you have to document a negative culture within 48 hours. So if the culture is if you have started your correct antibiotics and after 48 hours also the culture is positive, so then you have to be very, very cautious. You may have to upgrade your antibiotics, or you do have to do a proper source control. Look for a source. Where is the infection? Because number of days MRS is going to be in the blood, it is going to cause more and more problems, and chances of mortality increase. The treatment, empiric treatment for MRSA is vancomycin. You can give linezolid also. Daptomycin is a newer drug which can be used, but in there's a pneumonia. Daptomycin does not have a lung penetration, so you cannot give daptomycin for a MRSA pneumonias. But for a skin infection or for any other bacteremia, daptomycin can be a good drug of choice. And you have to do echoes when the blood cultures are positive, because you have to find rule out an endocarditis. So a positive blood culture is, you have to treat as a sentinel event, and you have to actively hunt for a metastatic focus like bone, joint, valve, lung, spine. So if the child of with the MRS is not getting better, there are recommendation even to do a PET scan to find out where the lesion might be. Sometimes it's hidden in a vertebrae. So this is a fourth case. Again, this is not actually community acquired pneumonia. Just wanted to show the X-ray here. This is a child who all is a case of primary immunodeficiency. Keeps coming in out of the hospital for IVIGs because of immunodeficiency. He has recurrent lower respiratory tract infection. He has bilateral pneumonia, antibiotic. Lot of time getting admitted to the ICU. And this admission, he was admitted with fever and distress and had seizures. So, and he always comes with very high counts. This time also he had high counts, 25,000 with very high CRP. And this is the X-ray of the child. And there was this cavitatory lesion in the X-ray. So obviously with the cavitatory lesion, we did a CT scan, and it again showed that there was a presence of a lung abscess kind of a picture. And here I want this X-ray I've taken because here is the situation where you give higher antibiotics. You don't give just ceftriaxone because it's a hospital acquired. It could be child is coming in out of hospital. This is continuously on nebulization, sometimes home oxygen. So then that can give rise to water bugs like gram negative bacteria, or you can have even gram positive bacteria can happen in this child. So we gave a broad spectrum piperacillin tazobactam with a linezolid to cover for gram positive as well as gram negative infections. So what is the suspected bug here? So you have staph, you can strep pneumonia can be present anytime, H influenza. Gram negative infections come higher on charts because you're immunocompromised, Klebsiella pneumoniae, Pseudomonas, anaerobes, non-tuberculous mycobacterium. In this child, we had sent the fluid for TB, CB-NAT, AFB culture. So CB-NAT, AFB culture was negative. We grew Stenotrophomonas later. Stenotrophomonas is a water bug. So this child was on home oxygen. Mother was continuously nebulizing with the same nebulizer kit for long. So these bacteria can come, and the child obviously went home after 2 weeks of IV antibiotics. We plan to continue oral antibiotics for a longer duration. Now, what are the IV and oral antibiotics available for community acquired pneumonia? So, oral antibiotics which are common are obviously amoxicillin, clavulanic acid, azithromycin, clarithromycin, cefodoxime, clindamycin. These are very safe oral antibiotics for pneumonias. Cefixime, a lot of people write cefixime. We see a lot of prescriptions cefixime for respiratory tract infection, which is not recommended because cefixime is an antibiotic which covers gram negative, like your E. coli, your typhoids, so for a Shigella, that kind of infection rather than a pneumonia. And IV antibiotics, we've seen ceftriaxone works well, cefotaxime, vancomycin, clindamycin, linezolid. IV azithromycin, though it's available in India, it is not FDA approved, so should not be used because it can cause prolonged QTC interval and can cause sudden deaths also. So I've written it purposely. We have had a death with IV azithromycin long back, and after that, when we went back and checked the literature, it is not FDA approved. So obviously, even with Mycoplasma pneumonia, we use oral azithromycin. Along with, you can use a IV doxycycline if you are suspecting a macrolide resistant, or a IV fluoroquinolone like levofloxacin. Then what is the duration of antibiotics? So duration of antibiotics for a community acquired pneumonia, the standard guidelines say 7 to 10 days of oral or IV antibiotic, whatever the mode you're choosing. But there are studies where you have compared them with a shorter duration of antibiotics, uncomplicated pneumonia, healthy child, early improvement. Even 5 days of antibiotics have shown to be non-inferior to a longer course of 7 to 10 days. But if a child is coming with a complicated community acquired pneumonia, like we have seen in our cases, you have a effusion, you have a empyema, so duration of antibiotics would be longer, 2 to 4 weeks. And if it's necrotizing pneumonia with an abscess or an MRSA, the duration will be much longer of 4 to 6 weeks. So what is to remember about in this presentation is that pneumonia is in India we have very high incidence of pneumonia deaths, so we have to diagnose it early, treat it properly. Community acquired pneumonia can come with complications like effusion and empyema, and which can lead to higher morbidity and prolong the stay. So whenever there is a fever which is persistent with the community acquired pneumonia, always look for complications. Strep pneumonia is the leading cause of pneumonia in overall in the world in all age groups. Even though the vaccination has drives are there, India we have PCV coverage is only 6%. So even with vaccinated children you can get pneumonia, and most of the children in the country are not vaccinated. So strep pneumonia is common. Always suspect strep pneumonia with a when a child comes to you. And mycoplasma is another bacteria which will is very rewarding to treat once you diagnose it, because you are not the child is not you can stop all your ceftriaxones and your linezolid because these antibiotics don't work on mycoplasma. Staph aureus teaching lesson is that it's rapidly progressive. You have to do a source control rapidly, look for metastatic lesions rapidly, and multiplex PCRs are there to help you. You have to clinically use the PCRs. Nasal PCRs for viruses are very diagnostic, but for bacteria, carriage, colonization versus actual disease has to be clinically correlated. With the pleural effusion, yes, if you have a sterile fluid and PCR is positive, definitely the bug is there. Okay, so that was my last slide. Thank you. And any questions?
Dr. Amita, I think a very nice session. And what you have done is that you have really tried to simplify the things as much as possible, because this session is mainly for the DNB students, that how the different presentations can happen and how the complications can present, and then which are the different organisms which are more common in different age group, and simultaneously how to manage it. So I'm just waiting for some questions in the chat box from the students. Meanwhile, I will just ask you one or two things. So one thing is that when a child comes to us with uh, almost clear signs of pneumonia, and what are the, you can say, like any prognostic markers or any, you can say, like high risk factors in which a particular child is likely to get complicated pneumonia, or this particular pneumonia is likely to get complicated. So are there any risk factors or the cohort of the patients which are likely to get more complicated pneumonias?
Uh, Complicated pneumonias can occur in mostly any children, especially when we are seeing these days strep pneumonia. But obviously, a child coming with very high grade fever, with probably not vaccinated, history of not getting properly vaccinated, prior
Yes.
history of viral infection a week prior or something, and frequent use of antibiotics can land up with complicated pneumonias.
Yes, you absolutely correct, and I think probably like malnourished children, somebody who is suffering from some comorbidities already, like diabetes or some other comorbidities, somebody who is on immunosuppressants because of some reason, so they all can actually land up in different complications. So yes, definitely. You were actually mentioning some signs on ultrasound like POCUS about the pneumonia. Can you please tell us some, you can say, like identifying signs, like in a simple case of pneumonia, what you can say like signs will be available in POCUS if the pneumonia is getting complicated, like in case of pneumothorax or in case of empyema, what different signs are expected and in which space?
So commonly when we are doing focus for lungs, we see A lines are the normal lines which we see. If there is pneumonia localized, you can get B lines. You can get shed sign where the pleura is broken down, and you can see paper shred like white echogenic spots. And then you can see effusion also, especially bacterial pneumonia. You can see small uh, hypoechoic fluid present. And then when you are doing it regularly, you can see the increase in the fluid or increase in the shed sign. And sometimes in necrotizing pneumonia there could be a pneumothorax which may not, which will be may come little later, where you can do where you can see the lung point, where when you put on M mode you can see the barcode sign is present, and for pneumothorax. So The point where the barcode sign and your normal stratosphere sign comes is where that point is where you have a small pneumothorax. So it's a pathognomic of a pneumothorax. Sometimes X-ray is a late this thing for pneumothorax. Smaller pneumothorax can be diagnosed by doing focus.
Yeah, absolutely, absolutely. And one more thing, like for an example, whenever you are taking a child for vets, and at that time you need to really see some honeycombing in the pleural space, whether it is happening multiseptate, you can say like collections which are happening. Then at that time you can probably point out that. Can you also you can say like highlight that which particular child is good for, like I'm giving an example of empyema, which particular child is good for putting a intercostal drainage and probably some you can say like some diluting agents versus which particular child is good for vats. So vats versus intrapleural streptokinase, urokinase, or ICD. So how you will choose means like which is your preferred modality?
So actually, in our unit, we are mostly a VATS unit, but what the studies have shown, VATS, the result of VATS with by use and using your urokinase or streptokinase are the same. There's no non-inferior. So whenever you find a pus in the fluid, it's always better with the ICD in C2. Generally, we put in we put in pigtail catheter. So we should be putting in the fibrinolytic agents so that the empyema doesn't form and we are able to drain it well. The contraindication is a low platelet or a coagulopathy or a pneumothorax. In those are the things where you do not put a fibrinolytic agent, or the child previous history of some sort of allergy to this thing, which is very rare. But if the child is not getting better after putting fibrinolytic agents, or there is a lot of multiloculated diffusion or very thick septae which probably are not getting better after fibrinolytic agents, so you may have to go for VATS. Sometimes primary VATs can also be done depending on the unit's preference, but whenever there is pus in the fluid, it's always better to put in a fibrinolytic agent so that the whole of the it dissolves and it comes out through the ICD.
Yes, yes, yeah. So I think it was a very informative session, very very academically rich session, and I particularly likes your slides and simultaneously the flow with which you have chosen, and simultaneously some case discussion also. So the entire format, it was so catchy that I was actually enjoying the presentation so much and learning so many things. So thank you so much for doing this presentation for us. I cannot see any questions here in the chat box from anyone. So we will, I think, close the session here only. So thank you once again, Dr. Amita, for your precious time. Thank you.
Thank you so much. Thank you very much.